Bom dia a todos, seja bem-vindo ao Hematolog. Meu nome é André, eu sou médico residente de Hematologia e Hemoterapia. É um prazer estar aqui. Hoje a gente vai discutir um pouco sobre linfoma de Hodgkin e eu vou chamar aqui para participar com a gente, primeiramente, a doutora Juiliana, médica hematologista do Hospital Israelita, Albert Einstein. And Dr. Matthew, we have a pleasure to have you here. Dr. Matthew is an hematologist and an associate professor from hematology and hematopoietic stem cell transplantation from City of Hope, California. Welcome, Dr. Matthew. Welcome, Dr. Juliana.
Thank you.
All right, thank you.
So I want to start with talking about some changes we had in the upfront treatment landscape for Hodgkin lymphoma, because we have seen some major improvements in the outcomes of these patients in the several past years. We had, for quite a while, treating our patients with ABVD and BCOP, but in the last few years, we have some trials that show some benefits incorporating brentuximab and more recently nivolumab. So, Dr. Matthew, I wanted to ask you to walk us through where we currently stand in the upfront treatment for advanced stage Hodgkin lymphoma.
Yeah, absolutely. So thanks for having me here. So it's a pleasure to be here. So, we've seen a lot of change in the upfront treatment of Hodgkin lymphoma. So, we were stuck with ABVD, for decades actually, right? So ABVD was designed in the 1970s, I think in Italy, and we really have been using it since then. And so for many years, the long-standing debate in advanced stage disease was basically ABVD versus BACOP. And there's a little bit of a divide between, the Europeans preferring BACOP. In the US, we usually preferred ABVD. And there are many trials comparing the two, and every single one of them showed the same thing: progression-free survival benefit with BACOP, but no overall survival benefit, probably because it was harder to salvage the relapses. And then this was just the long-standing, debate, right? But at the end of the day, it was still the same two regimens that were used over and over and over again. And then we kind of knew what we would get out of ABVD, right? So, so we found that for patients who, again, most patients are cured with ABVD, even with advanced stage disease. And then the SWOG 0816 trial kind of gave us a benchmark for what to expect, right? So again, about 75-ish% 5-year progression-free survival. So not, pretty good, but could be better, right? So that was kind of the status quo for many years, decades actually. I would say the next change was when the RATHL data came out, right? So that was 2016, and so that was testing the omission of bleomycin for patients in a PET2 negative, so patients after 2 cycles of ABVD who had a complete metabolic remission as assessed by a PET scan. Then we found that dropping bleomycin did not really impact the results, at least from an efficacy standpoint, but it was clearly less toxic from a pulmonary perspective. And so that became the new sort of standard of care around then. And then kind of concurrently to that, though, was the trial testing the upfront administration of the antibody drug conjugate brentuximab vedotin, to the ABVD backbone. And so this drug came out in the early 2010s, and it was highly active, right? It is still highly active as a single agent. And then so there were early trials actually combining brentuximab vedotin with ABVD together, so all 5 drugs. And unfortunately, in that original phase 1 trial, there was 2 patients who died of pulmonary toxicity. And so the thought was, that was probably not feasible to test further. And so the next step was to omit bleomycin and then to substitute it with brentuximab vedotin. And that was tolerable, that was effective, and that led to a large phase 3 trial randomized between ABVD and then AVD plus brentuximab vedotin. And so that trial, known as Echelon 1, reported on the primary endpoint was met in 2018, which was a benefit in modified event-free survival. And that led to the approval of AVD plus brentuximab vedotin as in the United States for frontline treatment of advanced stage Hodgkin lymphoma. So that was the first new regimen in a very, very long time. So that was 2018. And then with longer follow-up over time, in 2022, subsequently, an overall survival benefit emerged. And then, so certainly if you looked at practice patterns in the US, from 2018, 2019, 2020, Even 2021 in the community, when you actually polled community physicians, see what people were actually getting, a lot of people with lower risk advanced stage disease would still be getting ABVD. Maybe with for patients with lower IPS scores for their Hodgkin lymphoma. But certainly when the overall survival data came out in 2022, you could see that even in practice patterns, there's a pretty dramatic shift towards using brentuximab vedotin in the front line. And then after that, though, it took decades to get to that point, right? We were stuck with ABVD for a long time, but since then, there have been a couple, new innovations that came actually very quickly. So the biggest one, and I think the one that's made the most splash, was actually substituting brentuximab vedotin for rather nivolumab, which is a monoclonal antibody against PD-1. So in the class of drugs that we call checkpoint inhibitors. So it's basically substituting that for brentuximab vedotin. So around 2015 or so, I think nivolumab was approved for use as monotherapy in the relapse refractory setting, when we found it to be incredibly effective, right? Over 2/3 of patients would respond to it as monotherapy. Duration of responses were very long. But even though now we kind of take it for granted that nivolumab AVD is a fantastic regimen, it was not clear that was going to be the case back then. We knew that it was very effective, but there was kind of a thought that, hey, maybe this is a little bit of a softer treatment. Is it really going to synergize well with chemo? So even back before brentuximab vedotin was approved, the plans were already in place for what would become the SWOG 1826 trial, right? Which was a 1-to-1 phase 3 trial comparing nivolumab AVD to brentuximab vedotin AVD. And again, this trial opened right around the time that BV-AVD was actually approved. So they made the very courageous call to choose that as the control arm, which again, in retrospect, was absolutely the right decision. It was not a clear decision at the time. And again, even though now everyone knows about nivo-AVD, but certainly it was not a foregone conclusion in 2018, 2019 that it was going to be better. In fact, a lot of people predicted it was going to be worse. And so when the trial, and again, those of us kind of involved in the trial had a sense early on which side was going to be the winner. But certainly it was very gratifying to see that, after decades of no change, brentuximab vedotin, made itself into the first line. And then we watched, just a few years later, nivo-AVD, pretty conclusively, be superior to brentuximab vedotin AVD. I mean, the magnitude of benefit for the SWOG trial was, at the 2-year mark for PFS, there's a 9% difference, which again, when we're talking about overall PFS is in the high 80, in the mid 80% range, a 9% absolute difference is huge, right? The hazard ratio is less than 0.5. And so that's subsequently led to widespread adoption of nivo-AVD for frontline treatment for advanced stage Hodgkin lymphoma, and at least in the United States, and from what I understand, many other places. So my colleagues in Chile also tell me that they're using it a lot too, at least in the private sector there. The other kind of concurrent development, to be fair to the the German group, which has done so much for our understanding of Hodgkin lymphoma, was the introduction of the BRCAD regimen. So Bayakop had been for a long time shown to be better than ABVD as far as curing more people upfront, but not in the bigger picture. Again, probably because of the toxicity of the regimen. And so they did a couple things to innovate with it, right? Number one was substituting dacarbazine for procarbazine, or rather dacarbazine instead of procarbazine. So a lot less impact on fertility, a lot less toxic. And then again, kind of like what we did with BV-AVD in Echelon 1, removing bleomycin and substituting with brentuximab. And so the BRCAD regimen was tested against Bayakop and in HD21, and that was found also to be significantly better and less toxic. And so that is another excellent regimen. I don't personally use it. I prefer using nivo-AVD. That's where my experience is. I don't have a lot of experience personally using the Bayakop like backbone. There's a lot more hematologic toxicity. And I am concerned about the amount of cytotoxic chemo. Even though it's a shorter course, maybe a little bit less anthracycline, but there's a lot of alkylator. A little bit worried about that for younger patients. And then also the trial with HD21 did include a somewhat lower risk. If you look at it compared to the study populations, they weren't really the same between those two trials. But having said that, it is a fantastic regimen. Certainly, if you don't have access to frontline Nivo and you only have access to frontline BV, I think that's probably should be the treatment of choice for a younger patient. And so again, I think both of these though have really shown, demonstrated PFS ranges, over 90%. Which is really unprecedented, and so that's been really exciting to us in the field, seeing as how now we can really confidently go into a patient with newly diagnosed Hodgkin lymphoma, even with bad advanced stage disease, and have a very high level of confidence that we're going to cure this patient.
We are fully agree with your talk. We are trying to use IVD for in the private setting, but we are now facing the reimbursement for this patient. So I think it's our major problem now. And one of the topics that I think it's very important that you just say before is about the long-term toxicities for these patients, because we're talking about very young patients, and we have a lot of, it's the reason that we prefer here to use Nivo AVD instead of Bricade for the patient.
Yeah, I mean, I think, we're used to sort of thinking about let me phrase it this way. I think from the standpoint of big doses of chemotherapy, we have some idea of what the toxicities long term are, right? Maybe the hit to fertility, cardiotoxicity with anthracycline, maybe the increased MDS AML risk, secondary malignancies, for instance, with kind of this BACOP backbone. I mean, those things we have some decades of experience with, neuropathy with brentuximab, which gets better but doesn't always go away completely. I think with Nivo AVD, again, overall, even though if you look at the SWOG trial compared to BV AVD, certainly there's much less immediate toxicity. But I do think that we do still need to be vigilant for maybe some of the longer term immune related toxicities. And so again, even though it may not be that common, certainly there's some data to suggest that it still could happen, right? And so the Pembro, there was a Pembro AVD trial, and then they actually collected all the immune toxicities over the next couple years after therapy was discontinued, and a number of patients had either developed hypothyroidism after. There was a one late case of severe uveitis, one late case of adrenal insufficiency, like again 2-3 years later. So I think that's also something, again, even though I think on the balance like Nivo AVD is much less toxic, I've treated a lot of patients with this, by and large they tolerate it really well, but there will still be patients that can't tolerate it, or they get severe toxicity from the Nivo, or maybe they get toxicity longer term. And so I think we still need to we need to follow these patients and be careful.
Perfect.
Okay, so we've seen that these new regimens have some really good results in the advanced stage disease, right?
Yes.
So that got us wondering if maybe we can incorporate them to limited disease, but at the same time, it requires a high level of success to change our current practice, because we know that the ABVD backbone has already yielded good results in this population, right? With
Yes.
long-term PFS around 90%. So do you think the PD-1 inhibitors or brentuximab have a role in the limited stage Hodgkin lymphoma?
So if you ask what I personally think of, I mean, to me it's a slam dunk, yes. The problem is from a regulatory standpoint, to really adopt it requires a type of trial that I'm not confident will ever really be conducted. That's the issue, right? And so again, there's a couple of things. Number one is, we are a little bit a victim of our own success, right? Because ABVD works so well in early stage disease, as you pointed out, right? Favorable risk disease, probably cure 90+%, especially if you decide to do radiation as well. Unfavorable risk, again, depending on why it's unfavorable, you're still curing probably 90% upfront. And so to beat that, to show clear superiority, be it by EFS or PFS or whatever, as you might imagine, requires a massive number of patients, right? We're talking about, again, many hundreds of patients, maybe another 1,000 patient trial. Those are very, very difficult to do. And so, yes, there's a number of smaller trials, right? There was that have shown, for instance, that PD-1 or BV based frontline treatment. So either BV-ABD. So there's been a couple BV-ABD trials. There's a Memorial trial. There was a REACH trial. I mean, it clearly works very well, right? And there's a hint, maybe even one of those trials that you, for instance, using BV-ABD may kind of eliminate the benefit of radiation. Although I would caution against sort of saying that categorically is a small trial. Coincidentally, the only trial that's ever really shown that you could omit radiation with no impact to PFS was that was I think either HD 17 or 18 with the Baycott backbone. You can clearly omit radiation, but anything short of that, I don't think we know for sure. But and then there was obviously also one Nivo ABD trial dedicated to early stage disease, Nival, right, from Germany. But unfortunately, that one was followed by consolidation radiation for every single patient. So we don't really know for sure. Even if a lot of us suspect that most of those patients would have been cured without it, we don't actually have the data to show that. And so, and to me, it's a little bit of a pity that the current cooperative group trial right now, which again, it's a very large trial, we're part of it at City of Hope, is for early stages disease is built around an ABVD backbone for the first 2 cycles, followed by BV-Nivo consolidation. So I mean, I'm hopeful that will be a positive trial, right? That one's randomized against further ABVD, but either way, it seems like we may be stuck with ABVD for early stage disease, for a while.
Great. And the other question that it's around us is about patients who are facing early relapse after the Nivo-ABD frontline treatment. So how do you rescue these patients?
So that's a good question. I think no one knows for sure yet, right? There's not enough data out right now. They're just individual cases, individual anecdotes. So certainly, the few patients that we've had with this, they tend to be truly refractory, right? At the end of the day, PD-1 plus chemo is the most powerful combo in Hodgkin lymphoma, be it Nivo-ABD, be it Pembro-GVD, Nivo-ICE. I mean, there's no question that, that's the go-to treatment when you really need a response, right? When you want a CR, you do PD-1 plus chemo. So if you don't get a CR to that, it's problematic, right? And so, the idea of maybe, yes, we probably try to incorporate BV, into those patients, but, especially if you're still thinking about transplant, right? And again, I mean, if you're not responding to Nivo-ABD, you almost certainly need a transplant of some sort. And again, right now, I don't know if even autologous transplant will be enough to overcome, the poor impact for these patients. So, but certainly if they're still chemosensitive in some way, I think I would still try to incorporate a checkpoint inhibitor, especially if you're going to transplant, since I think the data for a checkpoint inhibitor prior to transplant, whether it's auto or allo, reducing sort of post-transplant relapse, I think there's enough data that I'm convinced, at least. For auto, I'm completely convinced. So we have some data that's kind of, we have a large manuscript that's, been submitted, not published yet, so I can't, give too many details. But I think for auto, it's very convincing. For allo, I think there's enough circumstantial evidence. So I would still try to incorporate it. Certainly, if the relapse is later, I think it's a no-brainer to have PD-1 still. Now, if you're completely refractory to Nivo-ABD, what do you do? I have no idea. Like, maybe, a BV-based regimen, maybe try to continue the PD-1. But again, I don't know if auto will really salvage this. These may be patients that ultimately just need an allo. So
it's just speaking on the relapse refractory setting. We know there are some factors that is associated with a poor prognosis, like early relapse and advanced extranodal disease. But there are also some patients that may not go so bad, like our late relapse, limited stage disease. And do you think it's mandatory for all eligible patients to go to autologous stem cell transplant?
So that's a great question. A lot of thoughts on this, but so certainly there's no question that there are patients who do very well long term without transplant. Like that, we've seen those patients. There's patients that have a late relapse in one spot, they get radiation and it doesn't come back, or I mean, we've all seen those patients. I think number one is it's very difficult prospectively to identify who those are, right? And so, one of the problems is that, transplant has been so entrenched as like the curative therapy of choice for, in the second line or, whatever line setting, if you've never been transplanted before, as long as you're still chemosensitive, right? That's been kind of hard to knock that off, right? So actually, I'm going to circle to that one, right? I'm going to circle back to that question in a second. But one thing I wanted to point out also is that, all these traditional risk factors for so-called high-risk relapse, right? Primary refractory disease, extranodal, relapse, B symptoms when you're relapsing, et cetera, right? Those were established in a time when all we had was chemo, right? So we were doing, you're doing ICE or GemOx or GDP or whatever, in the second line setting, and it's valid for that. However, it's not clear that any of those things really still matter when you're using PD-1 based salvage regimens, and this is actually something that we've seen consistently in the PD-1 plus chemo salvage. So with Pembro ICE, Pembro GVD, Nivo ICE, in all of these. Basically, all of these prognostic factors like go away. Certainly for primary refractory, like the curves are identical in every one of these trials. Interesting though, it was not the same with BV-Nivo, right? So BV-Nivo was kind of our first chemo-free, was kind of the first PD-1 based salvage that really sort of was published on, right? So it was published in Blood in 2018. We started the trial in 2015, and it works. It was a beautiful, it's a beautiful regimen. It's fantastic. We still use it once in a while to take patients to transplant. Especially for patients who just got ABVD frontline, and you get BV-Nivo, no chemo, you go to auto, and we cured, most of them. But for the primary refractory patients, they didn't do as well with BV-Nivo. Whether this was a sample size effect or whether there's really something that different between PD-1 plus chemo versus BV-Nivo, I don't know. But one thing that we've seen is that again with PD-1 plus chemo, perhaps none of these risk factors really matter. And actually. We saw that in our large retrospective study, actually, of transplant patients. Now, going back to the question, so again, if you do PD-1, then again, I think all these things go out the window. But having said that, the other question though is who can we cure or who can do fine long term, without transplant? I don't think we know for sure. That is something we're looking at, right? So so one thing that Memorial Sloan Kettering did was. They were the group that designed Pembro GVD, and then they subsequently had a second cohort to the trial looking at Pembro GVD followed by Pembro maintenance with no intention to transplant. And so the Pembro ran for about a little less than a year, right? So actually it was 17 doses in total of Pembro, which again that's right around 1 year, right? 51 weeks or so. And then at the 2-year follow-up, right? So theoretically 1 year after stopping all therapy, most patients had not progressed. Actually, it was around 60. So again, it was right around 60%. So a little bit glass half full, half empty, right? In the eye of the beholder, whether you think 60% is good enough or not. And then what they found though, in sort of a pre-specified analysis, was that the curves kind of separated very sharply depending on whether you had extranodal disease. So for them, that having extranodal disease, the large majority of patients relapsed, right, around 70%. Mm-hmm. The ones who didn't, it's less than 30%. Again, I mean, whether that should be the deciding factor, I think that the numbers were too small. So that's why they're running a randomized trial now for transplant versus no transplant to look at this question further. But I think that will help us. Sort of figure out which patients might be able to skip transplant. And again, they also have data showing that even if you did relapse without the transplant, you could still get them back into CR and salvage them with a transplant. And in their experience, pretty much none of those patients relapsed with more chemo followed by transplant. And then one other thing is that, anecdotally, we have a few patients, who either for some reason refuse transplant or, refuse transplant basically. We had a few of those on BV-Nivo. We've had a few in all these salvage trials, even the ones that were intended for transplant. Sometimes the patient just gets there, they're in CR, that I don't want it. or we've had some success, again, kind of not unofficially, radiating sort of residual disease, or even if they're in CR and it had a limited relapse, it's kind of radiating the area of the disease. We've had a number of patients not actually relapse after that. It's not really published, but that would be something to consider. And then also we had a BV-Nivo, right? Actually I think it's still open, a BV-Nivo second line trial with no intent to transplant. So you get about 8 cycles of BV-Nivo instead of 4 as a bridge to auto. And so we'll see what the long-term results for that are. And again, the desire was to see for patients who either don't want transplant or who are transplant ineligible, can we cure at least a few of these with BV-Nivo by itself? And so I have a Jehovah's Witness right now who actually went through that trial, went into CR, and now because she had a limited relapse, she's receiving consolidation radiation to the mediastinum. So we'll see what happens.
That's fair.
You just clarify a lot of questions now with this talk. So one other question is about maintenance. So we have very old data about maintenance, and we have a new upfront treatment. So how can you do that?
Oh yeah. So to me, I think the maintenance question is pretty straightforward. But I may be a little bit biased. So there is only one therapy that's approved for maintenance, right? People always talk about PD-1 maintenance. There was a Pembro trial published. We did BV-Nivo maintenance for 8 cycles. Both of those are definitely not standard. I don't think they'll ever be standard. And our experience with BV-Nivo maintenance actually also was that it was pretty toxic. A lot of patients ended up needing steroids for one reason or another, and maybe it's because early post-transplant, you're hitting them with BV-Nivo between day 30 or day 60. Maybe their bone marrow niche isn't totally reconstituted yet. That's probably not the best time to give PD-1 blockade. Just we've had some gnarly side effects. So there's that leaves just BV, right? And that from the Athera data, but that was very strictly for patients who just had nothing but chemo, right? Your ABVD, ICE, auto like patients, where we know that for again for these high risk features, that you're gonna cure less than half of these patients, right? And when we saw in the control arm of the Athera, right, 5-year PFS is 41%. That's not what you want to see after auto, right? And that's not what we expect anymore with PD-1 salvage. But that's kind of the point, right? With PD-1 salvage, it's not a 50-50 toss-up whether you're going to cure the patient or anymore. It's probably closer to 80-90%, right? And I think that's generally eliminated the benefit of maintenance. And that's actually what we've seen in, again, our retrospective data, in a very large, retrospective analysis. So there's a kind of, and when I say retrospective data, I'm kind of referencing, so we have a large multi-center consortium that's looked at over 1,000 cases of auto transplant, looking at the impact of salvage, looking at the impact of maintenance, everything you can think of, right, for such a large data set. And then one thing that emerged, and there's an ASH abstract on this from our group back in 2023, finding that we didn't see any benefit for BV maintenance if you had BV pre-transplant, and also if you had, but more importantly, if you had PD-1 blockade pre-transplant. So but even before this data came out, our general practice at City of Hope, and this is just kind of our style, right? I'm not saying this is the right thing to do, but for patients who only had one Athera risk factor, right? So let's say you relapse within a year, but that's your only risk factor. So no extranodal disease, et cetera. We would have a discussion with the patient, about maintenance, but then also say that it's not clear that there's that much benefit to maintenance in this group, right? I mean, if you look at the, again, even going back to the Athera paper, that for patients with one risk factor, the hazard ratio is like 1, right? There's no benefit, and we know that ongoing BV maintenance is toxic, right? I mean, how many patients have you had get 16 doses, right? They all stop like at 10, right?
Yes.
Neuropathy, they're all complaining and they're done, right? And so certainly, we weren't that gung-ho about maintenance, right? People with one risk factor, we generally were like, do you really want it? We kind of talked to them, and in my experience, most patients would decline it. But then the other thing also is that right around when that came out, most of our salvage patients actually were getting PD-1 salvage, right? Because we had the BV-Nivo trial, and then as soon as that was done, we had Nivo ICE, right? So practically speaking, the large majority of patients who were getting transplanted at City of Hope, we're getting Nivo before transplant, in some fashion. And obviously, in retrospect, we look like geniuses, right? But I mean, we didn't know prospectively that was going to be so important, right? That I think that actually, really, eliminated any benefit from maintenance. So short answer is, for any patient that gets PD-1 prior to auto, no maintenance. It's done. To me, it just, I see no reason to do it anymore. I think it confers extra toxicity with no benefit.
Perfect.
Okay, perfect. Are we done, or can I ask more on the question?
No, we have one more question about future. I think it's important.
Yeah. Happy to talk about that.
So,
this is the part I'm not so excited about.
Yes. So, what do you think about the whole future of the landscape of Hodgkin lymphoma treatment?
Yeah, so this is a big problem, actually. Well, I mean, again, like glass half full or empty, right? Is this half full or half empty, right? The reason I say that is I mean, the immediate future is really exciting, right? I mean, if you have a newly diagnosed patient with advanced stage Hodgkin, you're overwhelmingly likely to get cured, right? And and this benefit really, for also another plug for Nivo AVD, right? This benefit really extends to older patients. You saw with we know with ABVD, with BVAVD, your PFS, your PFS EFS is kind of in the 60-65% range. It's always been significantly lower than with younger patients just because of toxicity, right? BVAVD is brutal for old patients if you've ever used it. In fact, it was to the point where we would split it up, where you give BV by itself, give a little AVD, then give more BV, because if you gave it all together, you would just give horrible neuropathy. So, but having said that, right, Nivo AVD with older patients, same as with younger patients, right? It's really remarkable. So again, one more, I couldn't resist, another plug. But and so that part's really exciting, right? The future for newly diagnosed patients is very bright. We're going to cure almost all of them. If you never had PD-1 and so if you relapse after ABVD or even BVAVD, we have a very high chance we're going to cure you with PD-1 plus chemo plus transplant, and we're going to find out maybe which patients don't need transplant. I mean, that's all exciting. But for the patients who have relapsed after multiple things, they're in a little bit of a rough spot, right? As far as novel therapies, we have very little coming. And one reason for that is it is very difficult to get pharma investment in this field now, because there's Hodgkin lymphoma was never the biggest field to begin with, right? There's not that many patients, and we were curing most of them up front, even for decades. But there was still a critical mass of relapsed patients. There was still some interest. But just to kind of put it into context, right? The CD30 CAR T, which it flamed out a little bit in the phase 2 trial. The company went bankrupt in the middle of the trial, and they stopped it, right? The CD16 CD30 bispecific, right, from Affimed, so much promise, right? They gave it with pre-complex NK cells. They presented on it a couple years ago at ASCO and ASH. The CR rate was like, initially it was like almost everyone, but as it settled out, the CR rate was like almost 80%, almost 100% overall response rate. It was really fantastic. There's so much excitement, so much buzz around it. And so they did a different trial that was kind of very similar, but a little bit easier to do. So you didn't have to pre-complex it with NK cells. They gave it with an off-the-shelf NK cell product. It was an oral presentation at EHA, I think at ASCO also this year. Company went bankrupt. Right. And so, but it goes to show that even if you have something promising or something that clearly has some effect, it is so, but the pathway towards either, again, financially or just to make it viable for development, even whether you're a small company or a company that just has that one drug like Affimed, it's just so difficult to move forward. And even for large companies, they've all pulled out of the space, right? We're talking about, PD-1 in early stage disease, right? I think if someone were to actually run the trial, I mean, I don't think there's any question that it's going to be better than ABVD, right? I mean, it's better than advanced stage disease. I mean, it's kind of hard to imagine it's going to be worse for that in early stage disease. And I think we all think that it would probably eliminate the need for radiation, but we may or may not really ever get that trial of PD-1 plus chemo just straight up with no radiation. Like that might not happen ever. And none of the large companies that have checkpoint inhibitors are interested in running this trial. All the alternative checkpoint inhibitors have also been pulled, right? Like Merck with their LAG-3 inhibitor, which again, the response rate in PD-1 refractory was modest, but for the 30-ish% of patients that responded, duration of response was I think 18 months or something. It was really remarkable. So there's still some activity, right, with favezelimab, as their LAG-3 inhibitor. but they were about to open a phase 3, and then financially they decided it wasn't worth it, so they pulled it, right? So that's kind of what we're facing, But again, having said that, there are still some there are still a couple people trying to come up with novel therapies, right? So there is a novel CD30 antibody drug conjugate from Seattle Genetics with a different payload, so not the same as MMAE, so not a microtubule directed therapy, but rather a kind of a novel camptothecin backbone. So that one's in clinical trials right now. So we have that open at City of Hope. And there's a couple of small molecules coming down the line too.
And work like a T-cell engager, this molecular?
No. So we don't have. So there's no. So there was one bispecific that was that made it to clinical trials, right? So that was from Genmab, the same group that made epcoritamab. So kind of the same sort of, the same technology. So they did a CD30. They did a CD30 bispecific, and then they had a couple pretty severe rashes in the phase 1, and then they pulled the drug. So it's done. And so there's no T-cell engagers, bispecifics. There's no real CD30 CAR T that's really active in the United States under development. And so certainly again, immunotherapies beyond checkpoint inhibitors, and again, checkpoint inhibitors specifically like just PD-1 like blockade has been again a lot of initial excitement, but sort of as the reality sets in, it's not clear that that there's that much there going forward.
Well, still speaking on what we can expect for the future, we've been using PET response-guided therapy, and PET has become the standard to evaluate response for almost all lymphomas. But it's not a perfect tool, right?
No,
I mean,
not at all.
Some patients can have a negative PET and still relapse after a while. So I understand people were investigating another tool to evaluate minimal residual disease. And one way to do that is to identify circulating tumor DNAs through targeted sequencing, right?
Yeah.
So can you tell us more about how you think that can change the approach for Hodgkin lymphoma?
Yeah, absolutely. No, I'm glad you brought that up. I probably should have mentioned that as something to be excited about, right? Because that does seem like that's better than PET. And so PET scans, we knew that predictive value of PET scans. I mean, that was with treatment with ABVD, that was pretty well established, right? I mean, in that it wasn't perfect, but it was like okay, right? So for and then a PET scan, your interim PET scan done after 2 cycles of ABVD when you're intending to do 6 cycles, so again, our benchmark was that if you were PET2 negative, your PFS is 75% or so at 5 years, right? At 2 years it was like low 80s, and then it would kind of drop a little bit every year. Whereas if you're PET positive, we knew historically that with ABVD that your cure rate would be, again, the numbers are a little bit fuzzy, but probably in that 30 to 40% range. So again, I mean, it's not, although if you think about it, that's not really the best, right? It's not separating like 95 versus like 10%, right? It's like 75 versus like 35, 40. And then not to mention, right, there's all these cases on the border, right, where you're looking at it really hard, you're measuring it, and the liver's like 3.4, and this lesion's like 3.5. You're like, do you radiate? Do you escalate for that, right? So I mean, we I mean, I'm sure you've seen this, we've seen this, right? I mean, this comes up all the time. I mean, in our practice, we usually just give 2 more cycles and do another PET and see what happens, right? But if it's really close, right? But certainly, even with ABVD, like we kind of knew, there was at least some value, right? And again, theoretically, you're supposed to escalate if you're PET positive after 2 cycles because you probably weren't going to cure them. But it's still the level of certainty you had wasn't perfect, right? And then with BV-ABD in Echelon 1, we found out that even if you're PET2 positive with BV, that at the end of 5 years, that the PFS was still close to 60%. So not that far off from escalated Bayakop, right? When you escalated to Bayakop after 2 cycles of ABVD and it was still PET positive, our historic benchmark was you cured about 66%, about 2/3 of those patients are cured, right? So like it wasn't even that different, right? If you had a PET positive after BV-ABD times 2. And so that kind of led to us saying, so even with that, we kind of already were like, well, we would still often do a PET scan after 2 cycles. Part of it is old habits die hard. Part of it is collect some data. Maybe you can look back at it later. And then I think one thing that's another sort of colleague in the field brought up was that still you have some patients where you look at that PET2 and you're like, oh, this is bad, right? I mean, like the mediastinal mass, it's like still like on fire. Like that one, you kind of have a sense it's not going to work out, right? So, you know, or they're already progressing, right? To kind of catch like the few cases where you're truly like blowing through your frontline therapy. But even then, you know, I have colleagues who, you know, don't do a PET2 for BV-AVD because, you know, they're just like, what's the point, right? I'm not going to change my therapy on this. For PD-1 plus chemo, the data are kind of everywhere, and it's a little bit, it's kind of a little bit hard to know where I don't even really know where we stand as far as PET scans, right? So, and I'll get to the ctDNA question, but with PET scans, you know, we've seen a few kind of wildly discordant results, right? So there was a small trial with pembro AVD where you gave pembro by itself for 3 cycles followed by AVD. So that was conducted by Dr. Pam Allen out of Emory. And that was a trial that made a lot of buzz when it came out because the PFS was 100%, right? 32 for 32, like saved, you know, for frontline patients. And then every patient was in CR on PET scan. Like they did, I think, 1 interim PET and then 1 at the end. Like every single person was in a PET negative CR. And then contrast that to concurrent pembro AVD where, again, they had 1 or 2 relapse events after like many years. And so PFS was like, you know, in the high 90s. And then they had a 33% positive PET scan, you know, after 2 cycles, the PET2 was positive a third of the time. So, you know, it's tempting to say, oh, maybe that's because it's sequential, you know, and then now if you're just giving unopposed, you know, AVD after that, you know, it's not that the PD-1's not mucking up the PET scan. I mean, it's kind of tempting to say that, but, you know, there's no way we have enough data to make any sort of pronouncement like that. So I don't really know where that discrepancy comes from, you know, and also we saw some, you know, even though the data weren't really, that we didn't have the long-term follow-up, but also, you know, the end of treatment PET scan in the very first trial of Nivo AVD ever done, which was actually from the pivotal checkmate trial, they had 1 cohort that actually got Nivo AVD, and this was published in 2019. The end of treatment CR rate was only 82%, whereas we know that that's a way underestimate of what you would expect for the cure, right? So I don't think we know. So with PET scan, but certainly there's a suspicion that it may not be the best. Now, having said that, you know, it is also increasingly clear that ctDNA actually is something that we can follow in Hodgkin lymphoma. So despite the relatively small amount of actual tumor, right? When you do a biopsy in Hodgkin lymphoma, there's not that many Reed-Sternberg cells. You get a lot of like stromal cells, you get a lot of like macrophages and microenvironment, but the actual cancer cell, there's not that many neoplastic cells, right? But having said that, you know, ctDNA is viable. You can actually, you know, you can measure it, you can follow it, you can watch, you can see the quantitation go down. And we saw this nicely so a couple of things, right? We saw this in pembro AVD. So in the trial from University of Washington, they did collect ctDNA at baseline. They were able to, you know, get the baseline for most of their patients, and then they followed it along. And then they found that it did correlate well, right? That one of the relapses did correlate. So there were only two patients with persistently positive ctDNA at the end, and then one of those 2 relapsed. One of them actually, interestingly, never relapsed. And then the ctDNA data, it was actually for the SWOG trial, it was presented at Lugano. So my colleague, Dr. Herrera, presented it. And it was interesting, right? It clearly there was a correlation, you know, and you know, clearance of ctDNA by, you know, after cycle 2 was, you know, I mean, as you might expect, was good. But although it wasn't, the discriminatory value wasn't perfect, right? Even if you had a positive ctDNA at cycle 3, day 1, I believe like the 2-year PFS was still over 60%, but it was negative. It was like well over 90%. You know, so there was some difference. Although again, may not that, you know, whether that's the best time point is a little tricky, right? And so one of the things going forward is, you know, number one is, you know, is it, you know, actually number one is you know, accessibility of ctDNA testing, right? Right now, the kind of the assay that's the farthest along is SpaceSeq, right, from Foresight Technologies in the U.S. But that is a very expensive assay, right? And it's not really considered standard of care right now, yes. And so that is very cumbersome. And so one issue also, and then that's kind of leaving aside, like, you know, how exactly this is going to be exported to the rest of the world, right? And then the other thing is also, you know, with the regimen that works so well, you know, certainly it's, you know, like what exactly are you gonna, like, how exactly are you gonna use this, right? Like, what time point is optimal, right? Because, like, we know that cycle 3 day 1, yeah, there's predictive value, but even if it's positive, what are you gonna do with it, right? But yet it's so expensive, you can't, in the ideal world, you would check it with every cycle and try to figure out, maybe is there one that really like kind of yeah, and they actually look at the sort of the log clearance, right? If you didn't clear by 3 logs, you kind of, that's kind of some alarm bells too. But still not good enough to be like, oh, this patient clearly needs alternative therapy, right? Because ultimately, if you have expensive biomarker test, you want it to be actionable, right? You want to test it so you can make a decision off of it, right? But if it's like tells you the difference between like 90% and 65%, and you're not going to change what you do, right? So then can you justify doing this very expensive test, right? So I think it's exciting in the sense that, I think certainly it's prognostic, right? There's no question that it's prognostic. Is it really actionable? What's the best time point for it to be actionable? What would even be your action, right? If it's like, if you find that you're not getting optimal ctDNA kinetics with Nivo AVD, like, well, what are you going to do about it, right? Like, how are you going to actually save this patient? So that, in my mind, and again, all these questions will need answers, but to answer all of them will be very difficult. But that is, that's one thing going forward, right? So one trial that is about to open is actually looking to de-escalate Nivo AVD on the basis of ctDNA. So for ctDNA for ctDNA negative patients. And so we have a pretty good idea that those patients are going to do well, right? So for people who clear their ctDNA, we're going to see if de-escalating to just 4 cycles of Nivo AVD plus 2 more cycles of Nivo monotherapy will yield good results. And I think a lot of us are excited about that. And so, and I think, one thing about, future directions is, sort of de-escalating Nivo AVD. Nivo AVD times 6 for everybody is probably over treatment, but exactly who can get less, 4, 3, even maybe 2 cycles, for some people, that's, probably like, I think that's one of the next frontiers.
That's very interesting. That was a great discussion. Thank you very much, Dr. Matthew, for joining us today. Thank you, Dr. Juiliana.
Thank you for having me.
Thank you, everyone who joined us today.